everybody. This is Chris.
And Kathy.
We wanted to take a minute to thank you all for tuning in. We appreciate every listener and are grateful for this platform.
Please help us share our vision by subscribing to our show through your favorite streaming app. Follow us on Facebook, Instagram, TikTok, and YouTube at Petability Podcast.
Check out our ever-growing list of affiliates and sponsors. Simply go to the show notes for information and links.
And be sure to use our promo code PETPOD22, that's PETPOD22, on checkout to receive your discount from our affiliates. And now, here's a word from our sponsor.
Hi, I'm Alon Landa, CEO of MedcoVet, and I'm a proud sponsor of Petability. We decided to partner with Chris and Kathy because, like them, we want to empower all pet owners who are trying to do the most for their pets. At MedcoVet, we specialize in advanced home laser therapy for pets. Laser therapy is a safe and effective treatment for common conditions like arthritis and wounds, and it relieves pain for most conditions caused by inflammation. With MedcoVet, pet owners can perform this treatment at home while receiving support from experienced clinicians. If you think your pet would benefit from healing at home, visit medcovet.com, and one of our clinical experts will work with you to determine if home laser therapy is the right fit for you and your pet. Tell them Petability sent you.
Understand that it's an alignment problem, and we need to figure out within each individual pet what that alignment problem is and take a patient-specific approach.
Welcome to Petability. I'm your host, Kathy Simons, certified veterinary technician, certified canine rehabilitation practitioner, and certified hospice and palliative care technician for pets.
And I'm your host, Chris Cranston, licensed physical therapist and small animal physical rehabilitationist.
Our podcast provides interviews and information to help your pets live their best lives.
Good afternoon, Kathy. What you doing over there today?
Good afternoon, Chris. I'm doing all right over here. Got a little story for you. 2 nights ago, it's 3:00 in the morning, and I hear a duck outside my window in the courtyard, and she is quacking. She's so angry, and I can't see her from my window, and I'm afraid to go out there because I don't know what she's angry about, right? I don't know what's happening. It went on for like 40 minutes. And then the next day, I'm getting Mac in the car, and here she comes out of the courtyard with her 10 little babies, right?
Aww.
It's so cute because she gets to the curb, right? And she hops down, and the babies are like, oh my gosh, it's a cliff. It's a cliff. And they commit to it because their mom's like, come on. And they crossed the parking lot and went over to the pond over here. It was so nice to see. It was
Well, when you said she was quacking angrily, I mean, maybe at work, I'm thinking like some sort of predator or something was in her midst, and she was doing her best duck imitation of Mama Bear, right?
She was mad. But it looks like everybody survived, and they waddled their way over to the pond. I haven't seen them since, so hopefully they found their way over there.
Well, 'tis the season, being spring, so I am happy to report that the mourning doves have returned and are nesting under the house.
Nice.
And last week I saw the shell of the egg, below the nest. Yeah. I'm like, oh, okay, we got a baby. And last year there were 2. I think there's only 1 this year, but this morning I got out the binoculars and peeked. And because Mom was I could see she was getting like crowded out,
Yeah.
And I saw its little head, its little mottled head and beak and one eye, through the binoculars. So I will keep you posted on how many, hatchlings there actually are. And hopefully they will survive as well. Let's get to it. I'm sure our listeners are anxiously awaiting what we're going to talk about today. Yeah. So on Petability Podcast today, not only do we have an esteemed returning guest, but we're revisiting a condition that many veterinary professionals and pet owners may feel they already understand, and that is patellar luxation. We actually did an episode called Patellar Luxation, What You Need to Know, spelled K-N-E-E-D. I thought that was so clever. I came up with that one with an orthopedic surgeon in August of 2023. So go back to that show and compare and contrast with what you're going to learn today. So again, we covered the basics of this condition in that episode and included how it's diagnosed, graded, and traditionally managed. But like many areas of veterinary medicine, our understanding doesn't stand still. So in this episode, we're shifting the focus away from what patellar luxation is and into something much more important, how we think about it and how that thinking is evolving. So our guest today is veterinary orthopedic surgeon, Dr. David Dycus. And he's been sharing emerging insights that challenge some of the long-standing assumptions in how we evaluate and treat these patients. His work invites us to look at this condition differently, thinking beyond what is present now, and moreover, toward the long-term ramifications of a chronically unstable kneecap, no matter the severity. This isn't about discarding what we know, it's about refining it. And for clinicians, rehab professionals, and dedicated pet owners alike, this shift in perspective could meaningfully change outcomes for the dogs we treat. So in this conversation, we're going to explore where traditional thinking may be falling short, what Dr. Dycus is seeing in practice that's prompting a different approach, and how this evolving framework may shape the future of patellar luxation management. With that, let's dive in and welcome back to the show, board-certified veterinary surgeon, internationally recognized speaker and teacher, published researcher, and owner of Fusion Veterinary Orthopedics in Maryland, Dr. David Dycus.
Welcome, Dr. Dycus.
Hey, thank you so much for having me. I'm thrilled to be back.
I'm thrilled to have you back. And I'm interested really because I was telling Chris off air, I was like, my dog has a grade 1 luxating patella. And in my mind as a rehabber, I'm like, okay, we can manage this, but maybe I need to rethink that, right? Maybe I need to rethink it, especially as he's approaching 9, right? Maybe I need to consider some of the things we're going to talk about today.
Yeah, absolutely. I think there's certainly some things that we can discuss to not only talk about how patient in the situation is very similar to your dog, where we can maybe do some things. Sometimes we don't always have to jump to surgery. But I think what's really important is we start to redefine how we think about the kneecap and its movement and effect on the knee itself.
And realizing that many listeners may not have heard the other episode or even realize what a patellar luxation is, can you just do a quick reintroduction, I guess, to explain what a patellar luxation is and how it affects dogs' movement and quality of life?
The best way to think about the patella, and the patella is essentially the kneecap. We have them at our knees as well. You can easily feel it. And the kneecap should really live in this little groove at the bottom of the thigh bone or the femur. And the best way to think about it is kind of like a pulley system. So we have our quadriceps, which are the big muscles on the front of your leg. And when you contract your quadriceps, your knee will extend. And that's because from the quadriceps to the kneecap, and then from the bottom of the kneecap down to the point of your shin, that's what's called the patellar tendon, that helps redirect that line of action. And so if the kneecap is moving out of place, whether it moves inside of the groove or outside of the groove, that will affect that pulley system and therefore affect the ability for the knee to function appropriately. And so that can result in a mechanical issue because the functionality isn't there, but it can also result in a painful issue because it's creating inflammation in the joint, but there's also cartilage in that little groove, and there's cartilage on the underside of the kneecap. And if it's moving in and out, that's creating some abnormal wear and tear on the cartilage, which then will set up the environment for arthritis to form in the knee.
Is this a clinical pattern that you've been seeing? Is this what kind of made you start questioning the traditional approach? Is that you're seeing these dogs as they age with significant osteoarthritic process?
That's absolutely correct. In our environment in veterinary medicine, we focus a lot on arthritis of the knee as it pertains to a dog tearing what's called their cranial cruciate ligament, which is the similar nature to our ACL. And that would be the number one cause of dogs developing arthritic changes and the number one cause of dogs limping or having issues. But the other part of arthritis that forms between the end of the thigh bone and the kneecap, a term we call patellofemoral arthritis is one of those things that I think goes under-recognized, but it also creates a lot of pain and discomfort. And the thing to really realize with a patellar luxation is that it's considered a developmental orthopedic disease. So, in other words, it's present since right after birth. There's an abnormality, and what's important to understand is the patella moving out of place is sort of the collateral damage to the real underlying reasoning of why the kneecap's moving out. The kneecap moves out because there's a mismatch between the skeleton and the soft tissues. So really, this is a big deformity problem. And there is some genetic reasonings why the dog may develop a deformity. And if that happens, then the kneecap has a tendency to move out of place. And so what happens is these dogs may come to me at a very young age. These dogs may come to me later down the road when they start limping. And a lot of the times when they come to me later down the road when they're limping, it's because they've got arthritic changes in the knee. And so it got me to thinking about if I had just seen these dogs earlier in life, or if I had maybe been more aggressive in doing something earlier in life, perhaps we would have either eliminated the chance for them to develop arthritic changes or dramatically slowed the process down so that it doesn't clinically affect them. And so my approach in how I go about recommendations and workups for patellar luxation has really evolved, trying to be very proactive instead of retroactive.
Oh, I have so much to say.
Yeah.
First, I want to divulge my faux pas. Dr. Dycus and I are both on a vet rehab listserv, and our colleagues pose questions and share cases and so forth. And well, I don't know, maybe a month or two ago, somebody said something about a grade 4 patellar luxation and the need for surgery. And I pipe in thinking I know what I'm talking about. And I say, I thought that grade 4, which is, quote, the worst, were not a candidate for surgery, because when I learned about this, 20 or so years ago, they were saying there was so much damage already in existence around the knee. And basically that kneecap is dislocated and it's stuck out there. And even if you put it back in place, all of those soft tissues, as you mentioned, Dr. Dycus, so that's joint capsules and ligaments and tendons and fascia and all of that, have been stretched and deformed to the degree that the surgery would not be effective in the long term. So long-term success was poor. And Dr. Dycus jumps in and says, absolutely not. These pets with this condition, first of all, should not be graded in terms of severity, and that surgery would be indicated in this case. I thought I was being really punny, and I said that I stand corrected that all patellar luxation should be corrected, and got no humor, no laughter or anything thereafter. People are very serious on this listserv. So anyway, and then that's what got me to thinking. I'm like, we have to have Dr. Dycus back on the show. And if I'm in the dark, then I'm sure there are a fair number of other, people out there, pet owners and rehabbers and,
maybe it's time to change the model here. You know what I mean? And I'm interested to hear, if we're grading them 1, 2, 3, and 4, with 4 being the worst, what's the new model, Dr. Dycus?
Yeah, that's an excellent question. And by far and large, the majority of people, surgeons included, will still put a grade on the patella luxation. Why do I think that's a bad thing? So, number one, every dog that has a patella luxation would require us putting them into a little bucket of 4, meaning a 1, 2, 3, or 4, because in reality, there's no other grading system other than a 1, 2, 3, or 4. And so people sometimes will see a dog and they're like, well, it behaves like a grade 2, but it might be a grade 3. So then they would start saying, well, it's a grade 2 to 3, or it's a grade 2.5, or it's a high grade 2. And that's all very subjective and frankly just doesn't exist. And what I found is that not all dogs fit into a little bucket of 4. The other problem with the grading system is we used to use it to, number one, make recommendations for management, whether that's conservative or surgical. And I feel like that put a lot of dogs that would have benefited from surgery into a category where they didn't get surgery and then they show up to me years later with a really horribly arthritic knee. But it also, we used to dictate what surgical procedure we would do based on the grade. And what we learn is that following surgery, we don't want the kneecap to pop back out. But the reluxation rate in studies was anywhere from like 7 to 40%. And, if my surgeon said, listen, I'm going to do this surgery, but there's a 40% chance of what we're trying to fix is going to reoccur, I'm not going to sign up for that surgery by any means. And so what I do is I try to say there's going to be a subset of abnormalities for a dog that allows the kneecap to pop out. My job should be to figure out what those abnormalities are for that specific patient so I can create a patient-specific approach. And what we find by doing that, the chances of the kneecap popping out are essentially 0% because we basically correct what we need to correct for that individual patient. And what I found, these so-called patients we used to say have a grade 2 and would need very minimal things, sometimes actually need more advanced things. And some dogs that have the severe patellar luxations, the grade 4s, might not always need the severe aggressive management strategies as some of the others. So it's sort of all over the place, which is why I think grading's created some confusion and led to a number of dogs that should have been treated ultimately lacking getting some sort of treatment for life because they had a so-called low-grade patellar luxation.
I used to work at Angel Animal Medical Center when I was the assistant supervisor of the radiology department. And we would get these dogs in and we would x-ray them. And then you would go, okay, you see the two views. You go, okay, maybe it's in, maybe it's out. But when you do a cross-table x-ray and you see how shallow that groove is and the patella just floating on top of that, it really gives you a sense of, wow, that kind of brings it home to me like, okay, that's a shallow groove. We've got to repair that. So it makes me think, if you're doing individual repairs, are we talking about, or maybe you could describe some of the most common repairs, because some of my patients get things like, well, maybe they just get a lateral imbrication, or maybe they have a patella tendon transfixed with a pin and wire. What's the customized plan here for patients?
Yeah, absolutely. And it's interesting you brought up the radiology side of things because I'll use radiographs to get kind of some initial information. But when we take an x-ray, we're only able to take one view in one plane. And at most, we're typically able to get like 2 planes, usually one from the side, one from the front. There's a whole lot of information we miss because we're dealing with a 3-dimensional object. So the first thing I do is recommend a CT scan for my patients, because what I'm able to do is look at, in the 3-dimensional space, the relationship between the thigh bone, the shin bone, and the foot, and where the kneecap is. And then I'm able to break down each bone. What is the alignment of the thigh bone? What is the alignment of the shin bone? And then I can essentially create what I'm going to do in surgery before I actually get into surgery. And so, prime example, if there is a deformity within the thigh bone, sometimes that means cutting a little wedge of bone to straighten it, or if it's too twisted, we untwist it to make it straighter. I'm also able to look at the depth of the groove, as you mentioned, and on a CT scan, we can actually measure the angle, and we have cutoff values as to what that should be to tell us if it is of appropriate depth or if it is too shallow. And then I can also get a little bit of a gauge of how severely affected the groove is with perhaps arthritic changes or how much destruction has been done to the groove. Because if we have a patient that the groove is shallow, but the cartilage integrity inside the groove is appropriate, then I can deepen that groove and they can maintain their native cartilage. But if I have a groove that's shallow and there's a lot of destruction of the cartilage within the groove or a lot of damage to the groove, then I can do what's called a trochlear groove prosthesis. I can resurface or replace the groove with a prosthetic groove to create a frictionless surface. The other thing that's interesting with CT scans is that with the groove, we're now finding all sorts of different abnormalities to the groove that are allowing the kneecap to luxate that we never really recognized. For example, the groove itself could have a deformity to it. Or I had a patient recently where the groove was actually narrower than the patella. So the patella was actually just sitting on top of the groove because the groove didn't develop wide enough. And then I'm also able to then look at the shin bone and I can see if the point of the shin developed a little too inside, or meaning it was moved over to the inside a little too much, and thus we may have to make a cut in the point of the shin to slide that back over to help realign it, secure that with some pins and wire. Or if the shin bone itself is twisted, we might actually have to make a cut in the shin bone to take that twist out to straighten it. And so the whole goal is to reestablish the alignment so that the skeleton and the soft tissues match up appropriately. What we used to do in the past by simply saying we're going to deepen the groove and make a cut in the point of the shin and do some soft tissue changes, we were essentially trying to force the soft tissues and the patella into bone that was still crooked, and we were trying to force it where we thought it should go rather than correcting the bone to bring the bone to the patella, because the patella is technically where it's supposed to be. It's the bone that's out of place. And with that approach, we tend to see a lot higher success rate and a lot less complications.
Can we just talk about the
amazing.
prosthetic groove for a minute? Because that just blew my mind.
Well, it's really cool. There's several different little systems out there. It's basically a kind of a partial joint replacement. And so especially these older dogs, they have really severe arthritic changes. It can make them very comfortable very quickly. And so we can replace the groove. We can also get kind of outside the box thinking with the advent of 3D printing. For example, the dog that had the deformity where the groove was narrower than the kneecap, the dog's bones are straight. There's no abnormalities for me to fix other than the groove. But if I were to try to deepen the groove, well, the patella is still just going to sit on top of it. So we actually worked with a company in Italy to develop some 3D printed implants that go on top of the groove that actually are directed to create a wider groove for the kneecap to sit down in. So we're able to actually fix that issue with personalized 3D printed implants. So there's a lot that we can do with the world of 3D printing and patient-specific approaches, but we have to just gather the information, and where that comes into play is with a CT scan. So I think for me, a CT scan is a very, very valuable piece of equipment when it comes to planning for patellar luxation repair.
Again, I have so much to say. So I'm 60 years old. I had arthroscopic right knee surgery. They graded it 4/4 osteoarthritis in my patellofemoral joint. I have no cartilage on my femoral groove and minimal cartilage on my patella. I had a extreme inflammatory response following, and they said that's not uncommon following arthroscopy. And I had 35 cc's of fluid drawn off my knee at 7.5 weeks. But I looked up, Dr. Google, and I'm like, what's normal for a female knee? And they said 0.4 to 4 cc's. And I had 35. For the listeners out there, if you have any sort of joint pain, but in particular, knee pain, it's so common to have arthritis, and the source of it may not be where you think it is. It could be, right under that kneecap. And, that's kind of what we're talking about today. I also wanted to just ask you, Dr. Dycus, all this stuff sounds expensive. CT scan, surgical correction, and not just like simple things. I mean, you're talking about, derotating bones and, so on and so forth, like maybe multiple things that need to be done in that surgery. So how do you approach that with a client?
Yeah, that's a great question. And, number one, I think one of the joys of me being an independently and privately owned practice is I get to set my prices. And my goal has always been to be the fact that I want to be able to do these things and I want to be able to help pets. And so therefore, my pricing is probably a lot less than other specialists, especially with my CT scans. And then the way that we do our surgery is we have a set fee, and it doesn't matter what needs to be done. It's one fee, so we don't have to sort of have all these plus and minus and what if kind of thing. But if we have a client that says, you know what, that all sounds great, but I just cannot afford to do that, then I think we have to have a discussion on expectations as well as arthritic management. Because since it's more of a deformity problem, it's not going to magically solve itself, but maybe we can do some things to at least make the joint environment a little more conducive to hopefully improving comfort and maybe slowing down progression. And that's where any patient with arthritic changes, I'll tend to have some of the same discussion with clients that tends to revolve first around weight control. The leaner they are, the better they're likely going to do. I tell them if you let your dog get overweight, that's a surefire way to make clinical signs worse. We need to have some sort of daily activity, and I break that into daily playtime. That's where dogs love to do things outside. They love to run around. Dogs love to speed up, slow down, and twist and turn. But the worst things they can do to their joints are speed up, slow down, and twist and turn. So they can have daily playtime, but we have to be cautious or cognitive of how long and how often. And the other arm of daily activity is daily exercise, and that's going to be controlled leash walking. That's the absolute best form of daily exercise in these patients. And then we'll talk about the usage of things like omega-3 fatty acids or fish oil supplements, potentially injecting what's called a polysulfated glycosaminoglycan. There's a product called Adequan we can use, as well as various joint supplements. And then I'm going to counsel them on recognizing when their pet may have a period of a joint flare-up. So some worsening of discomfort, which the first step to get that under control is going to be through an anti-inflammatory. And then as things progress, we might have to work on some muscle strengthening. So we might start out with periods of physical therapy, knowing that the physical therapy itself is probably not going to improve the patellar luxation, but hopefully improve muscle mass and calm down the joint discomfort enough so that they can still compensate a little bit better. We might have to think about joint injections to calm down the inflammation. And we might have to eventually later down the road think about activity modifications, or they move into more of a maintenance physical therapy, because a lot of these dogs will start to become like tight rubber bands from compensation, which that in and of itself can create some discomfort. And by improving that, we can thus improve their comfort levels. So we move from saying this is a surgically correctable disease that we can do something to fix the problem to more, okay, if we're not going to be able to directly fix the problem, how do we best manage it to minimize pain and discomfort of the joint?
The abnormal forces of the luxating patella, do you think that it's a contributing factor in some of our patients who go on to have CCL tears? Because I often see them together.
You're absolutely correct. And we know that dogs, if they have an underlying patellar luxation, are at a slightly increased risk to tear their ACL, about a 15 to 20% increased risk factor. And that's because when the kneecap is out, it tends to want to pull the shin bone inward a little bit because it's connected to the point of the shin. And one of the functions of the ACL is to prevent excessive internal rotation of the knee. And so what it does is it puts the ACL under abnormal stressors. And dogs tear their ACL due to degeneration or breakdown over time. And so if there's a chronic abnormal stress to that, that can then exacerbate that risk for them to tear their ACL. So we will commonly see patients that are middle-aged or older that come in with a really significant limp, and it's because they've torn their ACL and they've had a previous history of having a patellar luxation that was a so-called low-grade patellar luxation that wasn't causing that much of an issue. But now the patellar luxation is actually worse because they've torn their ACL.
When you go in, is that a pretty easy fix to address both?
It does add a little layer of complexity. I would much rather address a dog with just an ACL tear compared to an ACL tear and a patellar luxation, because now we really have two problems to deal with. One is, how do we stabilize the knee? And then two is, how do I improve the patellar luxation? And so again, it's going to go towards looking at the deformities that that potential patient may have, and then weighing that against how they've done throughout life, the degree of arthritic changes in their age. So for prime example, a 3-year-old dog with pretty significant arthritic changes and what appears to have some deformities with an ACL tear, I'm going to stabilize the knee for the ACL, but I'm also going to do what I need to do to get the patella where it's supposed to be. Versus if I have a 10 or an 11-year-old dog that is adapted quite well throughout life with the patella, happens to tear their ACL, then I'm going to focus on getting the ACL squared away and then look at improving the patella luxation, but not go to great heroic lengths to completely correct everything, assuming that the dog has compensated relatively well most of its life.
Is that because you're weighing other factors such as time under anesthesia and things? Because I would think that the surgical approach for the two comorbidities would align, that, like you said, if the patella is out and then, that's putting extra forces on the CCL, that everything is moving toward the same direction versus being kind of opposing surgical strategies.
Yeah, no, you're absolutely correct in that. And it does come down to time under anesthesia, cost to the client. An ACL repair may take me 40 minutes. A patella luxation, if it's on the more complex side, could take, an hour and a half to 2 hours. And so now, we're now in surgery for 3 or 3.5 hours. And we also have to think about tissue trauma and a number of other factors. And so if the degree of arthritic changes is pretty significant, especially in that space between the kneecap and the groove, I'm going to have to do something about that, because even if I stabilize the knee will be stable, but if there's still really significant arthritic changes, that's going to be a source of discomfort. And honestly, those patients tend to do extremely well when we do a procedure to stabilize the knee. And in my hands, that's one called the TPLO. But then if we replace the groove, because they are very comfortable right after surgery, because now the knee's loading normally and we've taken away the source of pain from the cartilage damage in the groove that the kneecap lives in.
You had mentioned earlier that there was a genetic factor to the deformity. Who are those dogs?
So our poster children tend to be our small breed dogs, our Yorkies, Shih Tzus, Chihuahuas, French Bulldogs, English Bulldogs. Those kiddos we tend to see very frequently with patella luxations. And there's been some genetic work done, I believe it's in Yorkies, looking at some of the genes that could be responsible for some of the deformities. And so the general recommendation is, if we have a dog with a patella luxation, the dog should not be bred.
So you talked about the individualized, approach to surgery, and that makes 100% sense. Kathy and I are both rehabbers. You mentioned rehab and, maybe they need some strengthening and so forth. I think we all try to do an individualized approach and not do a cookbook approach. Some are better than others regarding that. But, is there something specific that you commonly recommend in terms of rehab that maybe we're not thinking of? I'll tell you something that used to really bother me coming from the human world as a physical therapist in sports medicine. We did a number of things when typically young women had patellofemoral problems, and it included, modalities, manual therapies, targeted exercises, stretching, fascial work. When I switched over to the small animal rehab world, it seemed that I was getting these referrals for, again, the grade 1, 2 patellar luxations, and they would just be quad strengthening. That was the recommendation. And I'm like, I guess because I was thinking it's a malalignment, it's the biomechanics of the joint are not appropriate. So why would exercises that force the quad to contract and then put extra stress on that joint be recommended?
Number one, I think on the human side, you guys are way more advanced in terms of conditions, pathophysiology, and exercises targeted to accomplish goals than we are on the veterinary side. But I agree, it doesn't make a whole lot of sense if it's a malalignment problem just to simply strengthen the quadriceps, because we can make the quadriceps super strong and bulky, and the quadriceps are still going to be in the same position, which means the patella is still going to be in its same position. There's some studies that are coming out, and they go way over my head because they're looking at nerve electrical impulses firing to muscles with specific exercises. So we can get a better idea of saying, this condition has a deficiency in these muscles. So if we strengthen just these muscles, we can start to improve on that condition. For a patella luxation, to be honest, I don't have a great answer to what specific muscle groups would be deficient or what muscle groups may be overpowering that we should work on. I think some manual work to really relieve some of the soft tissue tension on the side the kneecaps luxating is absolutely going to be warranted, because if the kneecap is popping in and out, and I don't know if you've ever had a joint that pops out, but I had a shoulder luxation, and when it popped out, it was, number one, it was extremely painful, but all the tissues around my joint just sort of froze up, like went into a constant state of contraction. And I like to think that if the kneecap's doing that, the tissues are going to start to really tense up. And then if that becomes a repeatable problem, then there's going to be this constant state of contraction and compensation to those tissues with a lot of trigger points. And so working out a lot of that muscle tightness is probably a good way to go, rather than perhaps strengthening, especially just the quadriceps.
People tend to, their kneecaps tend to go the opposite direction, to the outside versus the inside. But I did exactly that, what you were saying, as far as doing a lot of medial stretching, of the gross muscles, but also very specific manual therapy and myofascial work and 3-dimensional deformation and things like that on the medial side. And then trying through like lateral stepping and things to strengthen the outside muscles to help rebalance the biomechanics. And I did have a dog that was a hind limb amputee, and he had a luxating patella, and she started doing the home program stuff of just like the stretching and some massage, and he became asymptomatic in the sense of he was no longer skippy stepping, sitting down during walks, really lame. And I was like, this is a true blue miracle, but I digress.
And there's so much on that side of things that we just don't know in terms of the conservative side of rehab. And I think there's likely some degree of patients that we could absolutely improve their clinical signs and get away with. And then there are those that have just such significant bony deformities that it's just not going to be as successful. And that's where, unfortunately, it requires the imaging side to really make that determination. And I've even in patients that have minimal to no clinical signs, especially if they're young and they're skeletally mature, even recommended saying, well, let's at least get a CT so that way I can look at our alignment. And if our alignment is appropriate, maybe we can take a conservative route and keep an eye on things as long as we don't start to see arthritic progression, versus if I have a patient that has really significant malalignment, then have to have a conversation with the owners of, I understand the clinical signs right now are minimal, but we have to think about the impact and the integrity of the joint when the dog is 8 or 9 years of age, because we don't want them to go through life in chronic pain if we can do something about it. And, yes, it kind of stinks to have to do a quick sedation and get advanced imaging with a CT, but I think it provides us with a lot of valuable information and decision making of what we should do with some of these patients.
I just want to not forget my original question. Are you finding that after surgery and you correct these issues, that rehab is still indicated, or does that typically take care of the problem?
Well, I'm a huge proponent of rehab, especially in the postoperative period. So I do recommend that all of them get into a rehab program starting about 2 weeks out from surgery, along with a structured at-home exercise plan. And we'll typically rehab them through the recovery process, and then we'll start to return them back to normal activity. And what I found is that we don't necessarily have to continue rehab from a maintenance standpoint throughout the rest of life. But I think it certainly helps with gait retraining. It certainly helps them get the leg down. It certainly helps them build up muscle strength quicker and helps them get back to return to function quicker.
Also, it's mental expenditure when you have to sort of be in a
I tell owners that. I say, listen, not only is it going to help facilitate healing, but it's going to burn some calories and intellectually stim them, because, I'm going to tell them they're going to have to take their dog and we're going to have to decrease their activity level to avoid the explosive activities during recovery to protect the surgery site.
And Dr. Dycus, I forget, because you said after surgery and after rehab, getting back to normal activities. Once this is biomechanically corrected, can they go back to the things like agility, which includes stops, starts, turns, or is that still a no-no? I forget if we were talking about that in the sense of more conservative treatment or post-surgically.
Well, post-surgically, my goal would be for them to return to any activity with no limitations. So if that's a companion, playing in the backyard, going to the dog park. If it's a performance dog, that's going back to sport with appropriate conditioning. And if it's a working dog, that's going back to work at full function.
I like that you're saying that those dogs are going through a conditioning as well. So we're rehabbing them, and we're conditioning these dogs to go back to their high performance.
Yeah, because a lot of times they couldn't be as active either when they had this problem. So they become deconditioned over time. And again, addressing the compensations, right? Tight in the front end because they're throwing that weight forward. Their neck muscles are on fire because they're bringing their head down to decrease the load and weight on that bad knee, and so on and so forth. So
all that compensatory related stuff. And it makes me start thinking about myofascia. Now I'm thinking about Dr. Lori and her myofascia and how that can be restrictive as well.
Yes.
There are just so many things that we can do in rehab when we see these patients after they've been cleared by their veterinarian to come to rehab. There's so many things that we can do. And if I'm going to go back to my dog who had it, my very first dog who had a patella repair, had a patellar luxation and repair. And he had to have restricted activity. And I will tell you that I cried for like 6 or 7 days because he was feeling better and there was no way to explain to him, you've got to take it easy. But it's hard. It's hard on the owner too.
Absolutely. And I try to, when I'm dealing with clients that have performance animals, I try to get them to think about, like, on the human side of an athlete, if they have surgery, they're going to rehab. And then once they're cleared from rehab, they're not going to go right back into sport. They're going to have to start conditioning to be able to get back to sport, to minimize soft tissue type injuries and that sort of thing. And so there's no reasoning why we shouldn't treat our canines in the exact same way.
maybe you already said this and I missed it, but can you discuss again, like the realistic expectations? You already said, you want them to get back to everything, but what kind of timelines are typical, like for a pet that is returning, to running around in the backyard versus what an athlete might expect?
Yeah, I typically will end up clearing them to start getting back to normal activity at around 8 weeks. So we'll take weeks 8 to 12 and we'll get back to the normal level of activity of a companion. So I call that normal dog status. And then if we have a performance animal, we're typically going to take weeks 12 to 16 plus on conditioning. And depending on the condition of the animal going into surgery and how they've done postoperatively, will dictate if that conditioning period needs to be 4 weeks, 6 weeks, or maybe 8 weeks.
And barring any setbacks.
Correct.
And also, we're throwing around this word conditioning, but you mentioned Dr. Dycus, like not returning to sport. I think that, you mimic gradually sport specific activities, breaking those down into smaller components. And then finally you start to put it together, but maybe at a reduced speed or, so there's this whole spectrum of graded activity from, like you said, that 2-week mark up till, normal dog status or returning to sport. And I think when you do make the analogy with people, I think they get it. Somehow a lot of us pet owners just have way higher expectations for our pets than we do ourselves in terms of getting better.
That's absolutely correct.
You talked about the importance of the CT scan, and I get that, but so it's 3-dimensional, but it's also static. So how do you assess like dynamic stability, functional movement during these orthopedic exams when it comes to the knee and in particular these kneecaps?
So that is a very important aspect that has to come from the physical exam. And in the past, we would palpate the kneecap and we would say, can I push it out? Or if it's out, can I push it in? And that was kind of all we did. And we would say, okay, there's a patellar luxation. What I do is I have them standing and I start to just sort of look, what does their limb alignment look like? And then I'll actually lightly hold the patella, whether it's in place or out of place. And then I will start to move the whole limb through various forms of range of motion. And what I try to do is figure out where is the kneecap popping out if it tends to stay in place, or if it's out of place, where does it tend to want to go into place? Or if I can get it into place and I start to move, where is it fighting me to pop back out? Because we find that dogs are very dynamic. Some kneecaps will pop out as the knee is flexing. Some will pop out with the knee extending, and all sorts of variations in between. And so I think even before the imaging, really evaluating the movement of the kneecap through range of motion, not just palpating it to say, can you get it out or can you put it in, but to really figure out where and how it's wanting to luxate. So in my exam notes, I no longer put a grade X out of X patellar luxation. I actually describe what the kneecap's doing with my manipulation.
Can you remind people when their dog is skipping or holding that leg up, what that might represent in light of what you just mentioned?
So I would say the skipping is typically associated with the kneecap popping out and losing that pulley system. The offloading, like so when they're standing, if they're taking some weight off, there's usually a component of discomfort associated with that. And so there's probably the inflammatory aspect. And so it's easier just to take some weight off to let that relax a little bit. The more frequent the skipping, the more likely there is to be the generation of inflammation in the knee, along with concurrent cartilage damage. And it kind of is interesting to me because in the past, people would always be like, oh, well, they're skipping and it's a low-grade patellar luxation, so it's not a big deal. But in my mind, skipping means the kneecap's popping in and out, which means it's hitting over back and forth on the cartilage, which is likely damaging more of the cartilage versus if the kneecap is out and there's more of a mechanical problem because it's not really going in. And so I've always thought to myself, well, why do we say that that's not that bad? In fact, it's probably the worst thing that could be happening to the cartilage.
So, Dr. Dycus, I mentioned that I had a lot of fluid buildup following my surgery. You said that with your new approach, you're basically minimizing or eliminating, it's a better word, the amount of recurring patellar luxations. You got it down to 0%. Are there other common complications that we should inform pet parents about?
So in the immediate post-op period, a few things. One would be stress to the implant. So that's suture, plates, screws, pins, wires. They all have breaking points. They're all strong enough for recovery. They're just not strong enough to withstand the explosive activities. Infection would be another thing that we need to be aware of, as well as implant irritation. Sometimes where we're putting these implants, they're in areas where there's not a lot of soft tissue coverage, or there can be certain fascial layers that cross over the implants that as they're moving could create some rubbing, which could create some irritation. And so implant removal at the time of healing in some cases might be warranted. But outside of that, the biggest thing, especially in smaller breed dogs, is getting the owners to understand that they have to slow them down to an absolute snail's pace, because dogs will naturally speed up when they have an injury or are recovering from surgery because it's easier for them to cheat and not have to put as much weight down. And small breed dogs are notorious for learning if they just hold up their leg and run around on three legs, life is great. And so we really have to get them to slow down for them to understand that they can put the leg down, they can use it appropriately, and then to develop the confidence in using it. And in many cases, if we have dogs that are just reluctant to want to get the leg down after surgery, that's where physical therapy or rehabilitation therapy can come into play quite nicely in developing that confidence level for them.
There's nothing quite like that, too, when they realize that that leg is going to hold them. And then they're like, oh, okay, it is better to run on 4 than it is to go on 3. And we've been talking this whole show about dogs and their knees. But I'm wondering, is there a population of cats, Dr. Dycus, that get patellar luxations?
Yes, and cats are a completely different beast when it comes to patellar luxation, because a patella popping out of place in a cat can be completely normal for the cat. The only
really?
time we would recommend correcting would be if the cat has a patella luxation and it's causing them an issue. Cats usually don't have a lot of skeletal deformities associated with their patella luxation. Their patella is a little bit more human-like. It tends to naturally be as wide or wider than the groove that it's supposed to live in. So I see a lot of cats for patella luxations, but I rarely do surgery for patella luxations in the cat.
Mother Nature's been so kind to the cat. That's
right.
You know, they are amazing creatures. I'll say it again and again.
Sure are.
So, Dr. Dycus, do you feel like you're being heard? Do you think that other orthopedists and the veterinary community in general is starting to move in this direction? You know, is there truly a shifting paradigm? What do you expect is going to happen in the next, 5 to 10 years when it comes to these cases?
Absolutely. I think our European colleagues are very much on board. I think they're further along in advancement of patella luxation than we are. There's groups of surgeons in the United States, myself included, that are a little more proactive on the patella luxation side. And then there's still groups that are a little more on the older approach. I don't know from a training standpoint how much of being proactive is being taught to surgical residents. I don't think in the veterinary school a lot of veterinarians are being taught these concepts. And so What I try to do with my referring community is really reach out and have those discussions with them. So that way, if they see patellar luxations, if they're comfortable going into these discussions with owners early on, great. If not, recognize that it's a patellar luxation and just send them to me. And then we can start to work through that. I suspect, though, over the next 5 to 10 years, because imaging like CT is becoming much more widely acceptable, 3D printing, planning of CT with planning software in the three-dimensional space is going to become a lot more common. And therefore, we're going to see a lot more of a shift of surgeons looking at finding what's wrong rather than relying on what the grade is.
And I think, too, it's important that our listeners, the pet parents out there, do realize that going to see a board certified surgeon in this case is really important. Your vet that may do surgery, at their clinic is at this point not going to be qualified to handle this type of surgery.
And I would largely agree, especially if it's still this mindset of, well, it's a grade 2, so we're just going to simply deepen the groove and move the point of the shin over. We can get away with that in some cases, but there's also going to be the cases where maybe that wasn't the best procedure for that particular patient. And so I'm not a huge fan of grouping and just saying you have X condition, so you need this. I'm more of a fan of saying you're an individual. Let's look at your condition so we can tailor a plan to you. And that's where a lot of board certified surgeons are going to be doing that.
Dr. Dycus, as we're wrapping up, if you had one thing that you wanted the listeners to take away from this podcast, what would that be?
My takeaway would be to take the grade of patellar luxation, throw it out the window, understand that it's an alignment problem, and we need to figure out within each individual pet what that alignment problem is and take a patient-specific approach.
Also, can you let clients know, our listeners know, where can they find you? Because I think you also do some virtual consultations. Is that correct?
Every now and then, it gets a little difficult, we found, to try to put direct recommendations without hands-on. I'm a firm believer that when I get my hands on a pet, I can really find things that may or may not exist in having just a virtual consult. But clients are absolutely able to go to our website. It's fusionvetortho.com. And then I also have my own website, drdaviddycus.com. That's DYCUS. On social media, ortho_vet, that's Instagram, and then Dr. David Dycus on Facebook.
We follow you.
Fantastic.
We follow you.
And I also want to mention to please check out the previous interview with Dr. Dycus called Regenerative Medicine for Osteoarthritis.
Yes.
It was published in January of 2025. I was shocked when I saw that. I thought it was in the last year, but it's been almost a year and a half that we spoke with you. So,
wow.
Yeah. So again, January 2025, you can scroll we're up to about 170 shows now, Kathy. And or put in the search Regenerative Medicine for Osteoarthritis with Dr. Dycus.
Thank you, Dr. Dycus. It's always great to have you. I hope you'll come back when you have more things to share, please.
Oh, my pleasure. And I will absolutely happily come back.
Yeah, it's great because we learned so much and it's so groundbreaking, forward thinking, and truly technical, but you present in such a way that makes me understand. And if I understand, I know our listeners out there are understanding. So that's awesome.
That's good.
I'm the litmus test.
All
right. Well, have a great weekend, Dr. Dycus. We'll be in touch.
You all as well. Take care.
Thanks. Bye.
Bye.
Thank you for joining us. We hope you enjoyed our show.
Follow us on social media at Petability Podcast.
And please check out our affiliates and sponsors.
Simply go to the show notes for information and links.
Thank you and tune in next time.